And now we're on to the pathology section of the chapter. Be forewarned that there are a lot of diseases listed. But remember, this is a section to come back to a few times, review the major diseases that are covered, and to look for some key distinguishing features of each disease. It's going to help you keep them all straight. We'll also try to present the key clinical scenario relevant for most of the disease processes. Okay, buckle up. The first disease that we'll discuss is called achondroplasia. Remember the concept of endochondral ossification? This is what happens when it just doesn't work. Normally, patients will put down a cartilage framework to help form the structure of their long bones before forming bone over that scaffold. In this case, constitutive activation of FGFR3 inhibits cartilage-forming chondrocytes from proliferating. This means that patients can't grow out their limbs, and they end up short. That said, remember that not all bones grow by endochondral ossification. Remember which bones, long bones or flat bones, don't grow this way. Flat bones grow via membranous ossification. Because there's no problem with membranous ossification in these patients, they'll have a normal-sized head and trunk, though because their limbs are short, they're going to appear disproportionately large. There is a huge spectrum of osteochondrodysplasias. That's the family of diseases that include achondroplasia, but this is one of the more common ones. So what are they going to ask you about this curious disease? There are a couple of high-yield concepts about achondroplasia that you should know. First, this is one of the only diseases that increases with advanced paternal age. Most patients develop the disease spontaneously, but if it is inherited, it will be in an autosomal dominant pattern. Another important fact to know is that these patients will have a normal lifespan and normal fertility. Alright, let's have a flash quiz. Which bone cells are responsible for resorption and remodeling? Osteoclasts. Osteoporosis is an extremely common disease, and as is the spirit of the Step 1 exam, common diseases are always well represented in their question bank. Osteoporosis is defined as a reduction of primary trabecular bone mass, despite normal bone mineralization and lab values. See how this spine x-ray seems just too translucent? Not all osteoporosis is the same. There are technically two types of osteoporosis. Type 1 is postmenopausal. Do you recall the effect of estrogen on bone? It's anabolic. In menopause, decreased estrogen levels cause increased bone resorption. Type 2, on the other hand, is slow but steady loss of bone mass with age, which leads to osteoporosis. So, how do we assess osteoporosis? Using a DEXA scan and T-scores. The bone mass at multiple different sites is measured using this scan, and is compared against bone mass for younger individuals. If the bone mass is 2.5 standard deviations below the mean, they are considered to be osteoporotic. If bone density is 1 to 2.5 standard deviations below the mean, then they are considered to be osteopenic. You can review standard deviations in the biostats chapter. There are many clinical signs of osteoporosis. The first one, and one of the more common ones, is vertebral compression fractures, which clinically present as acute or subacute back pain, sometimes after mild traumas, but often after no real trauma at all, like stepping off a bus. Patients with osteoporosis can simply step off a curb, and the impact of putting their foot down that single step can cause a vertebral crush fracture. The classic clinical sign that you'll see for this on tests is point tenderness over the spine, usually along the thoracic spine. Often, these vertebrae won't fracture quickly, but rather they'll fracture gradually, leading to multiple subclinical vertebral fractures. These won't present as back pain, but rather loss of height and kyphosis. Just imagine the 5'2" woman who then gets her height measured at 4'10". What do you call this kyphosis? A Dowager's hump. Think about your respiratory chapter. What do you think this deformity does to total lung capacity? It decreases it. A second clinical presentation is with fracture of long bones, like the femoral neck or the distal radius, which is called a Colles fracture, which happens after a fall onto an outstretched hand. Look out for medications that can cause osteoporosis after long-term use, such as steroids, anticonvulsants, anticoagulants, and thyroid replacement therapy. These will be long-standing medications. Another classic question they like to ask about patients with osteoporosis is the medications that you can give them, not to treat the osteoporosis, but rather to treat other conditions in patients with pre-existing osteoporosis. Remember, old people fall down a lot. And what happens if they have osteoporosis and they fall down? They break bones, and in some cases, they even die. If you give them something that can cause them to fall down more, they will break more bones and have an even greater chance of death. So you have an old patient with insomnia, and they'll give you 4 options. Let's say zolpidem, a benzodiazepine, and diphenhydramine. All of them would work, but they would all increase the fall risk as well. The 4th option would be to screen for depression. Not a first choice for all doctors, but definitely safe to do and worth doing because depression in the elderly can present atypically. Remember to screen for depression and to avoid drugs that can increase drowsiness or affect balance, causing increased fall risks in the elderly. So if a patient actually does have osteoporosis, what do you think they could do for it? Well, prevention is important to emphasize in young adults. Recommend exercising and increasing calcium and vitamin D intake to improve peak bone mass, which generally occurs when patients are in their mid-30s. But even though you can't reverse time, you still have some options. One is to use bisphosphonates, which are very commonly prescribed. These drugs stop the action of osteoclasts. Other options include certain selective estrogen receptor modulators, or SERMs. You can also use calcitonin or pulsatile PTH, called teriparatide. We'll discuss the more common ones in the pharmacology section. Don't use drugs whose side effect profile includes loss of bone density. Can you name a common class of anti-inflammatory drugs that this includes? Glucocorticoids are classic. You'll read in your pharmacology chapter that also includes heparin. Osteopetrosis is an interesting disease and relates to an aspect of bone growth that we haven't touched on in that much detail. When you form bone, there's a sort of battle that's going on between osteoblasts and osteoclasts. Osteoblasts are forming bone quickly to ensure growth progresses steadily, but this often leads to bone being formed in a way that's a bit haphazard and not refined into good structure, like that which is needed in healthy, mature bone. Luckily, most people have osteoclasts to reshape this haphazardly placed bone by resorption. This ensures it is mature and well organized. Patients with osteopetrosis don't have normal osteoclast activity. This leads them to having thick, dense bones that are made of an immature substance. This X-ray shows dramatically dense bones. So even if you'd think bone would be extra thick and hence extra strong, these bones lack the refining and remodeling process, and actually are prone to fracture. In normal healthy bone, the center of bone is hollow enough for bone marrow to fill it. What happens in osteopetrosis? The marrow cavities are actually filled in. So what happens if you don't have much bone marrow because it's been displaced? Anemia, thrombocytopenia, and neutropenia, which can predispose to infection. This causes an extramedullary hematopoiesis, which, as you'll recall from the hematology chapter, refers to blood that is created outside of the normal bone marrow. However, this disease does not cause changes in serum calcium or phosphate, or in the ALK-Phos or PTH levels, much like osteoporosis. The gene defect to recall for osteopetrosis is a genetic deficiency in carbonic anhydrase 2. The X-ray findings are classically noted as Erlenmeyer-Flask bones that flare outward. And the clinical pearl that you need to remember, the sort of physical exam sign that would make you think of osteopetrosis, occurs because bone enlargement narrows foramina, causing cranial nerve impingement and palsies. So which would you rather, osteoporosis or osteopetrosis? For me, although these bones are pathophysiologically total opposites, they tend to end up just the same, with fragile bone that fractures easily. But osteopetrosis comes with a bunch of other complications, like cytopenia and extramedullary hematopoiesis. So I'd have to go with osteoporosis. Alright, how do bisphosphonates work? They stop the action of osteoclasts. Osteomalacia is a disease wherein bone is not mineralized properly. Basically, this results in bones being softer than they should be, with characteristic bowing of the long bones. Osteomalacia is due to a deficiency in vitamin D. Vitamin D, as you should remember from your endocrine lectures, is an important regulator of calcium levels in the body. Because calcium is low, patients will have a reflex increase in PTH, which will also decrease phosphate levels. Remember that PTH is the phosphate trashing hormone. If you are suspecting osteomalacia, these lab values would definitely help confirm your diagnosis. Why is alkaline phosphatase increased? Because osteoblasts require an alkaline environment and are hyperactive in this disease trying to build bone. Term rickets is not much different from osteomalacia, except that it refers more specifically to vitamin D deficiency in kids. Would you expect to see an increase in PTH in kids with rickets? Yeah, you absolutely would. Okay, let's have a flash quiz. What bone cell is affected in osteopetrosis? Osteoclasts. Paget disease is quite interesting, particularly because the cause remains unknown. Osteoblasts and osteoclasts in the body both function, but both work abnormally here. This causes the bone to appear much different than it otherwise would in a healthy individual. For example, here we see abnormal architecture, widened bone, disordered trabecula, and a gross deformity. This X-ray, on the other hand, shows sclerostic areas and coarse trabeculation in the pelvis. The appearance is not only at the macroscopic level like we saw in these X-rays, but also at the microscopic level, when looking at the architecture of the bone histologically. This can also be described as thickened trabeculi with mosaic pattern. The thought is that a viral illness may play a part in its etiology, but that's still not confirmed. The classic lab value that is abnormal is increased alk-phos, a fact that you may see on your boards. With diseases like Paget's, there are two things you should pay attention to. First, you should know the key catchphrases that will make the diagnosis, and also you need to know how the disease is going to kill you. Okay, so first, what are the catchphrases? Mosaic bone pattern, on the macroscopic appearance, and even on imaging is a giveaway. Long bone chalk stick fractures are also common. Imagine the way that chalk breaks, with a straight line across it axially. Healthy bone doesn't break that way because it's designed to have a lot of resilience in that direction, but for patients with Paget's, it's much easier to break the bone. Okay, so how's it going to kill you? There are at least two ways that Paget's disease is going to get its victims. The first is that AV shunts can form through the bone, causing high output heart failure, which, as you'll recall from the cardiovascular lecture, refers to heart failure in which the heart is able to pump a normal amount of blood, but that blood volume isn't sufficient to meet the body's needs. It can also lead to osteogenic sarcoma, again as a result of disordered bone growth. The classic clinical vignette will likely have an older male with increasing hat size and also hearing loss because of narrowing of the auditory foramen. While the latter could be similar to osteopetrosis, the labs, age group of the patient involved, and additional clinical findings all should help you to differentiate the two diseases. So what should you order? An alk-phos level to confirm your suspicion for Paget's disease. This CT shows widened bone medullary space and areas of sclerosis and an irregular cortex. Let's have a flash quiz. What is the effect of PTH on serum calcium levels? That's right, PTH increases serum calcium levels. Osteonecrosis, or avascular necrosis, occurs when the blood supply to bone is interrupted. It often presents clinically as pain that occurs with activity. The pain is throbbing in nature. To help you recall all the causes of AVN, we have a mnemonic aseptic. The A is for alcoholism, And do you recall which type of heme-onc patient typically gets avascular necrosis? Sickle cell patients, especially in the femoral head due to infarction. Other things can cause avascular necrosis, such as steroids, either endogenous or exogenous, pancreatitis, trauma, idiopathic causes such as leg-calf-Perthes disease, or Caisson disease, also known as the bends. If the blood supply is interrupted to a part of the bone that affects the joint, it can often lead to destruction of the articular surface, causing significant joint pain. What test would diagnose AVN? An X-ray. You will see irregular, non-uniform patterns of lucency and opacity in the affected region, with possible joint changes if the articular surface is affected. What is the most common site of osteonecrosis? In the femoral head. Why? Because the blood supply to the femoral head is quite tenuous. Let's have another flash quiz. What disease would you expect if your patient tells you he has an increasing hat size and an elevated alk phos level? Think of Paget's disease. The last 5 diseases that we've discussed so far are causing you to be a bit confused. Don't be surprised. They definitely sound familiar, but they have some overlapping features. Hopefully, what we're going to do here is give you some pertinent lab values that will help you wean down a differential that you're developing as you read through a clinical scenario. Your major labs for bone diseases will be serum calcium, phosphate, ALP, and PTH. These will help you differentiate what's going on. Okay, so let's fill in this table together. First off, 2 of these diseases have no lab abnormalities at all. Do you remember which 2? That's right, osteoporosis and osteopetrosis. Sometimes, in osteopetrosis, you may see decreased serum calcium levels. Similarly, Paget's disease has only 1 lab abnormality. And what one is that? An increase in alkaline phosphatase. These are not diseases that are caused by inappropriate hormone regulation of minerals. They're simply inherited or acquired defects in bone architecture. The final 2 diseases, however, are actually defects in bone mineral metabolism. In osteomalacia and rickets, patients have a deficiency of what vitamin? That's right, vitamin D, which causes them to have low levels of calcium. This triggers an increased PTH level to bring the calcium levels up, but in so doing, also drops the phosphate levels, because PTH stands for the phosphate trashing hormone. Osteitis fibrosa cystica is the name of a bone disease that accompanies hyperparathyroidism, as you'll remember from endocrine pathophysiology. There is primary and secondary hyperparathyroidism. Here you would expect that your initial lab value, PTH levels, will be elevated because that's the basis of the disease. In primary hyperparathyroidism, this unchecked increase in PTH in turn causes an inappropriate increase in the levels of calcium and also a loss of phosphate. Additionally, we're going to see an increase in ALP due to increased bone turnover. But what's dysfunctioning in secondary hyperparathyroidism? Kidneys, which may be failing and cause chronically low calcium levels. Because the kidneys aren't really doing their job, you're also going to see high phosphate levels, because PTH can't trash phosphate in the kidneys. These right here are the key lab values to differentiate between primary and secondary hyperparathyroidism. ALP is increased in both. Great job thinking through that table.